Welcome back to the broadcast. COVID-19 home-based care is what we'll be discussing this particular segment, as we get to teach you on some of the key things that you probably have not known about home-based care. The moment this was introduced and declared by the Ministry of Health, very many people were skeptical of how they would approach the same, how they would still have their loved ones and have this care and ensure that they get well. This amid that declaration that yes, our hospitals were headed to that point where they would be clogged up, and then this was the best proposal or option left, and it seems to be working. But then again, there are things that you need to learn about it if at all you have to attain it pretty well or achieve the same 101%. So that's what we'll be discussing, and Dr. Jeremy Gitau will be taking us through. Dr. Jeremy Gitau is the head of department at A&E, Department of the COVID-19 Response Team, and we're glad to have him this morning. Dr. Good morning.
Good morning.
Thank you so much for your time. Good morning. Yeah. And yes, straight to it. Home-based care came and we're all like, Sasa itafanyika aje. And up until now, we probably haven't gotten enough information down on ground on just how this can be implemented, or this can be achieved, or this can be successfully attained. And even the patients themselves that have the virus would tell you for free that they would feel much safer when they're in the hands of medics as opposed to when they're at home. So first of all, just what got the Ministry of Health being convinced that this would work?
So it's actually what we saw internationally.
Yeah.
And also because you remember when COVID-19 came, this was a very new disease for everyone. So nobody knew what to expect. Yeah. And initially, if you remember, everyone was getting admitted to hospital.
Right.
And it got to a point around, I remember it was actually towards the end of May, when all facilities were full.
Yeah.
So you're being called, hospital, we had set aside about 450 beds, all full. We couldn't admit more patients because we've admitted everyone who is turning positive.
Yeah.
So the ministry had to rethink its strategy. And what we realized, as much as most of these patients were coming to the hospital, most of them were stable. I'm sure you've seen videos on social media of people doing exercise, people just complaining, saying how the food is good and all that. Yeah. So we realized these people are fine. They have COVID, it's been confirmed, and it's positive from the test. So they do have COVID. However, their symptoms are not severe.
Right.
And even majority of them do not have any symptoms. So in fact, when you spoke to most of them, they were like, I don't have COVID. I don't know what you're talking about. So we realized if we continue with this trend and how the disease was spreading, it was not going to be sustainable. We couldn't contain the disease by just keeping everyone in the hospital. What
is in the symptoms that sparks the need of our patient being left in the care of professionals?
So we look at COVID symptoms. We classify them into about 4 categories.
Yeah.
So we have those who have no symptoms, and these are actually the majority of the patients. More than 50% of the people with COVID will not have any particular symptom.
Right.
The other 20 to 30 will have very mild symptoms. So probably just a cough, a sore throat, and even some people may even have a mild fever.
Yeah.
Then there are those now with moderate symptoms. So people with moderate will now people who start experiencing difficulty in breathing. Occasionally their temperatures will be very high. So we are talking about above that 7.5 all the way to 38.
Yeah.
So they start feeling unwell. And they may require oxygen at this time because they're having a difficulty in breathing. Then there are those who have now the severe disease. So these are people now who have more difficulty in breathing to a point where they require actually ventilatory support.
Okay.
So such patients, the ones with moderate to severe are the ones now who require to be in hospital. People with no symptoms or mild symptoms, those are people who can actually stay at home. And these are the majority. You find actually up to 90% of the people with COVID-19 do not have either no symptoms or very mild symptoms. And these are the people now out there in the community. You'll hear, hey, I had the flu, I had the cold. Most of the time, if you test, it will be positive.
Okay. So then there's that fear of proceeding to test. So in this case, then, is that what would be considered to qualify the individuals who are supposed to be placed on home-based care?
Yeah, so for you to qualify, it's you either have no symptoms or you have the mild symptoms.
Okay.
You do not require oxygen. That's those are the patients we decide that they can qualify for home-based care.
Right.
But that's not the only thing we look at. So one, you have no symptoms. Secondly, you do not have risk for developing severe disease. So you find so people who have risk of developing the severe disease are people who are elderly. So we are talking of people who are above. Anyone who is above the age of 65. Yeah. I think you saw the other day when the ministry said even about opening churches. So the elderly and the very young, like less than a year. So those are people who are at risk. People with diabetes, people with hypertension, people with what is called chronic lung disease. Yeah. And these are diseases like chronic obstructive lung disorder, which is COPD, or people with severe asthma. People who are immunocompromised, people who have cancers, people who are on drugs for either they had a transplant or something. Yeah. So all these people are people who are at high risk. Even though they may have no symptoms or very mild, they do not qualify for home-based care. All right. The other thing we look at is where you live. So if, for example, you're in a slum or in a facility where you're not able to self-isolate. Yeah. So you do not have your own separate room with its own bathroom, with its own, with a place where you're able to get your own food. So we say you're not able to qualify. The other thing we look at is, do you have someone to take care of you during this time? Yeah. So you find some people, as much as they have all this other thing, they live alone. So, and how are you going to take care of yourself? How are you going to get food? Because the whole purpose of self-isolation and home-based care is that you be at home for that period of about 10 to 14 days. So if you're going to be at home for that period, how are you going to get your meals? If you're not able to get them, that means you'll need to come out of isolation, and that way you spread the disease to more people. So those are the criteria that we look at, those 4 things.
I am curious, on the very same note, we're talking about 90% of people who have COVID, who are symptomatic. And probably, the ones who've been tested, a larger percentage is placed on home-based care, in regards to these numbers that we're talking about. And evidently, again, a larger percentage of the people in the country really do not enjoy the luxury of these luxurious homes and homes that would allow one to, self-isolate comfortably. Yeah. So, isn't it then placing the people at more risk?
So what actually the ministry has done is, if you remember initially, people who are coming from abroad were going for self-quarantine. Yeah. And the government had partnered with schools, hotels, where people would go and self-quarantine for 14 days. Then after the 14 days, then they would do the test, and if negative, they're released. Right. So what the government did is that all these centers that were initially being used for self-quarantine, they were converted for self-isolation. Right. So for people who are not able to self-isolate at home, they were being taken and taken to these facilities. At cost? So government initially was taking care of the cost, but I think it got to a point where people were required to pay a fee. Yeah.
All right, and let's talk about back again. Now you are able to do this at home, and you have a few individuals who can take care of you, and you equally have your family there that you needs to be protected. So just how then do we protect this other party? 101%, because by default they will come into contact with the person who has COVID.
So the other important thing I think I didn't mention, when you are considering the person, there must not be a person who is at risk of developing a severe disease. Yeah. So if, for example, where you live, you have an elderly person, a child, or a person with these chronic illnesses, then ideally we would ask you to isolate in a different place, because these people at some point may come into contact with you. Yeah. So what usually we recommend is, so you still have to maintain the same principles. You have to to make sure you're keeping your distance. If at any time you need to interact with them, at least 1.5 meters, and you must always be in a mask. Because what we've seen is, as long as you're wearing a mask and you are symptomatic, the risk of transmission is very low. The other thing is hand washing. So people have to keep washing their hands. When it comes to the utensils you're using, make sure you're using different. So, and preferably, if in your own room, clean your own utensils. And usually we recommend that you soak them in a solution where you prepare and you soak them for some time. And then after that, you wash them, and then you can keep using the same utensils. That way, you're minimizing the interaction. The same thing happens to your clothes. So make sure you're soaking them first, then wash them yourself. At least for the 2 weeks, you're going to be in self-isolation. Then that way, you minimize the risk of transmitting the disease to your family. The other thing we do is, if you're able to, it would be good to fumigate the house after the same room you are using. After the period has ended, because actually nowadays from discharge, which we'll talk to about, is once you're discharged, make sure the room that you are in at least gets fumigation, and no one enters for about 1 to 2 days. Then after that, now you can start using the room.
All right, I would assume that then answers the question of how this should be conducted, or how home-based care should be received. And then I would ask this: if you say you should at least try and fumigate this, in the event that you don't, could there be a recurrence of the same? And does it then mean that there are higher risks, or there are higher chances of one getting COVID afresh in the event that they proceed to do home-based care?
So the most important thing is, if you're not able to fumigate, at least soak your whatever you're using, your beddings, your utensils, everything that was in that room, you can soak it in the sodium hypochlorite solution, which you've prepared at home. Soak them there, have them washed, and at least close the room for at least 2 days. That way, if there's any infection or any virus that was in the room, then it will have died off in those 2 days. So you don't need. Then after that, now you can start using the room.
All right. Just listening to that, and in a way, in as much as maybe it could be, a step towards the right direction, a journey towards recuperating, it also brings in that picture of, you're officially a different person. You're officially a special person. Just how much can we do this and root out or segregate the same from stigma? Because automatically I would want to assume the stigma will arise when you realize that, your utensils are being cleaned differently, this and this is being handled differently, and now again officially people cannot come visiting. In as much as this was stopped, we are Africans with the culture of visiting every other time, so people cannot just come to see you because then you are treated differently.
I think people need to stop the stigma, and I must say maybe probably the way we presented the information to the public is what has created the stigma. But what we've seen is people need to realize that it's not my mistake that I got COVID. And it doesn't mean because they have COVID you still get it. We've seen families where you find even spouse and children, only one person has. And they've been living in the same house throughout. You test them even twice and they're all negative. So it doesn't mean when someone has COVID, they will spread to the next person. The other thing, it's not a death sentence. So it's not that once you're diagnosed with COVID, that the next thing you're going to die. So people need to stop the stigma, and people need to show love to these people. Because one of the things we realized, there's a lot of psychological emotion that comes with COVID. The fact that you've been diagnosed with COVID, first you're scared of your life. So if people are going to show stigma towards you, then that worsens. And remember, the stress itself can lower your immunity, and that can put you at risk of actually developing severe disease. So we need to show love to these people. We need to encourage them. And the good thing nowadays, there are so many ways of, you don't need to see the person. You can video call them and encourage them, even without having to visit them. So that will help a lot. And even people who have done well in the home-based care, people who are able to communicate and talk to people out there because of the psychological torture that comes with the diagnosis of COVID-19.
Are there special cases where one would be 100% asymptomatic and maybe they have pre-existing conditions and they would easily be released to home-based care based on how they've dealt with their pre-existing condition?
So what we do is, so once you're diagnosed with COVID-19, we recommend, if you have any of these risk factors, the diabetes, the hypertension, it will be good you go to hospital. Get observed for 1 to 2 days. If you remain stable, now we are releasing, especially like at our facility. We've started a home-based care program where these people who are positive, they are allowed to go home. And what happens is, as you're going home, make sure there's somebody following you up, because I think that's the biggest challenge we have.
Yeah,
if no one is following you up, make sure you have a doctor or a clinical person who is able to chat every day, because the other thing we require when you're at home is that you should be able to record, for example, your temperature.
Yeah.
So have a thermometer, and you don't need the guns that are quite expensive. Even a simple hand thermometer, the one you put on your armpit, that one is okay to monitor your temperature every day. The other thing we recommend is to have the oxygen saturation machine, where you're able to record your oxygen levels. So with those two, we're able to follow you up every day. So we'll be looking every day for symptoms. Do you have any cough? Do you have any difficulty in breathing? Anything else that is happening? So, and this happens for a period of up to 2 weeks. And then, so with someone following you daily and finding out how you're doing.
Right.
And that has really helped most of the patients, and we've not had to keep patients in hospital longer, even though they had these chronic illnesses.
All right, definitely someone would want you to expand some more on follow-up care, because it is crucial, and especially whether there are contexts as to, getting to the next facility or getting to the facility that, in the event that the unusual happens, because you could be asymptomatic, but then of course the situation escalates, and you probably need instant, professional care for that moment. So follow-up care, just how best can this be achieved? Are there emergency call numbers where you can call and you just get this?
So usually what we say is the number 791 that has been given by government.
Yes.
If you call that number, you'll get help, and they'll send an ambulance if you need evacuation. So the first thing is you have to know these numbers. And actually, when we are discharging patients, we have a hospital number where they get the number. In case of any issues, they're able to call us back, and you can arrange for how they're going to be evacuated. If you're being followed up by a different facility, the most important thing when you're at home is that you have to have the plan. In case they get worse, how am I going to get to the hospital, and which hospital? And your family members also need to know that. If you get to us, this is the number to call. This is the ambulance that will take me to hospital. And this is to the specific facility that I'll be taken to. Because we've seen some few patients who've worsened on home-based care and requiring evacuation. And if it's not done early, because remember the other thing with COVID, if it's diagnosed late as any other disease, if you present late to the hospital, and even, for example, for patients who require even intensive care unit, if you present late, the chances of you surviving from the disease also become lower. So it's important you have someone following you up and making sure that as much as you're on home-based care, you are attached to a clinical person who is following you up during this time.
And of course that is squarely on their business to follow up sometimes, because with patients, with the stigma that comes along with this, with the extra work that comes along with it, some would tend to just want to overlook what it is that they're supposed to do. So in this scenario, do we have also special medics that are centered to follow up on the same, just to find out whether this patient is okay? And after how long then should you go for the checkup? The stipulated 2 weeks, or
so the follow-up is so the government guidelines for home-based care are after 10 days of being asymptomatic, then you don't need, actually nowadays we don't recommend even the retesting. Reason being, what the studies have shown is actually up to 7 to 10 days of being positive, the risk of transmitting the virus is very low. The other thing that happens is at this time you have a dead virus, and it's likely also to get detected. We've seen people remain positive for more than a month, and these actually adds to their stress. So you find I've actually seen a patient who was positive for more than 70 days. So, but that doesn't mean they're spreading the virus. What it means is the virus is being, because the test that we do is called a PCR test. It's very highly sensitive. So even a small part of the virus, when it's dead, it will be detected. And that's how sensitive the test is. So, and this happens, and we've seen people remain positive for a very long time. So after 10 days, if you've been asymptomatic, then we actually discharge you from the program. However, what is happening now is that most places, before you go back to work, people want to, also because of the stigma, and also because of the psychological emotion that is coming with the disease, most people are preferring, hey, let me just do the retest to be sure that I'm negative. But otherwise, scientifically speaking, if after 10 days you've been asymptomatic, the likelihood of transmitting the virus is very low.
Okay, all right. So the biggest fear is in transmitting and not the, particular patient.
Yeah.
The biggest fear should be in transmitting.
Yeah, so transmitting the virus. But what we are seeing now is we are getting to a level of also herd immunity.
Yeah.
Where the virus now is widespread outside in the community. People have gotten it, so even spreading to the next person also will become low, and that would be the best thing. I know there's some studies coming up where we want to see how the herd immunity, the level of the herd immunity, and that will help to guide future plans for the ministry. Yes.
All right. Okay, so I am curious. They say CRT need a specific unapewa, and most of these people really just want to understand what happens when you're in there in the isolation facility, just what goes down there. And the other time we're being told, it's just an easy thing. It's a comfortable moment. It's not as bad as many would think unless it's on that critical moment. So when you are at home, what are you advised to do? What do you take? What do you drink? All these lemons and ginger stories, are they true?
So one, Corona has no cure as we speak right now. So, and I keep saying ni homa. Yes. So the same things used to do before. People had different remedies. When you get a homa, I usually take this antihistamine. I take, if it's for a fever, you take a paracetamol. People like a lot dawa, dawa, the ginger, lemon, and honey. So and those are the same things we even give the patients who get admitted to hospital.
All right.
So especially if someone doesn't need oxygen, then there's no other treatment they require, and they're at home.
What if someone would want to say that, I am not confident at home, I'd want to stay in the facility?
We've admitted a few patients, especially now those people either with small children or the elderly, but they just stay in the hospital, get a balanced diet, give them dawa daily, the honey, ginger and lemon, and then if they have a fever, we give them something for the fever. It's basically managing their symptoms, but no specific treatment, not unless the only specific treatment which has been shown to work is for people who are now on oxygen, and we've been giving them a steroid called dexamethasone, and this has been shown to help. The other antivirals, they've still a lot of research going on. They've not been proven to help much.
All right. In scenarios where people are attached, say maybe it's a husband and wife, and worst case scenario, mother and baby, and one of them is probably asymptomatic and the other is clearly showcasing the signs and symptoms of COVID-19. How do you handle this? I mean, maybe a mother should be with a baby and all that.
So some of those we've had to admit both of them.
Okay.
So if the child is small and there's no one else to take care of the child, we just go ahead and admit. We've even admitted mothers who've actually just delivered in the postnatal period. A mother who delivered like a day or 3 days ago, turns positive. You admit both because now you can't. It's worse for a child if you leave them without the mother's breast milk. They're likely to suffer from these other illnesses for that lack of breast milk that they would suffer from COVID. So we've had to admit both of them.
If you were to rate this process right here in the country, would you say it has worked so well?
I think the home-based care has really worked, and it has actually helped to reduce also costs, because you can imagine having to keep about 400 patients in hospital. That requires a very large pool of the healthcare providers, the PPE. So in terms of cost, that has saved government money. And also in terms of the follow-up, the ministry has been very effective in following up these patients. So we're able to trace most patients where they are located, and this has really helped. So that has really helped the government as well. So I can say the home-based care program has really been effective.
All right, that's amazing. And I mean, march out there and ask Kenyans whether they think COVID-19 is there. And I can almost guarantee you that 9 out of 10 will say it is not there.
Yeah, most people believe it's a hoax. They don't believe there's COVID. And I've met several people. In fact, we went for some meetings some time back where people know exactly where I work, and they ask you, are you sure you've seen someone with COVID?
And you see them every day?
I see them every day. And even up to date, we have patients admitted with COVID.
Like how many in your facility?
Right now, the numbers have gone down. Before, we used to see more than 300. At any given time, we had 300 plus. Right now, the most we get to is 30. So you'll see it's now currently in the last 3 weeks, we've not had more than 30 patients in the ward with COVID. But they are there. And that's what we are saying. As much as people think it's not there, we need to remember that our parents, our grandparents, are the people who are at risk of getting this severe disease. And people are still dying of COVID. I know right now there is not so much. People have stopped listening to the updates, but people are still dying. Every day or any other day, you are reporting a death in this country. So people, as much as we think it's not there, we need to still continue taking the measures. You need to wash your hands, make sure you are the social distancing, wearing of masks. So all those need to continue.
All right. Lastly, our recoveries are being, well, at least from the numbers that we've have been projected, and we've listened to the Ministry of Health, in numerous cases saying that yes, we have this number of recoveries, a majority of them coming from home-based care. Does it then mean that there is more that is back at home in comparison to what our facilities hold? Does it put a question mark on the kinds of facilities that we have today?
So the recovery is what is, remember the way so the way the patients are being classified as those who qualify for home-based care. There are people who are either asymptomatic or have very mild symptoms. So it is expected, even if they are in hospital,
automatically they would
recover. So in hospital, it means you're getting more sick people. Some are in ICU. And the thing, like in ICU, they stay for a very long time. You find people staying on a ventilator for more than 30 days. So in the hospital, you have more sick people. And that's why even the recoveries are few. Also the numbers, the ones who are now getting admitted are fewer than the ones who are on home-based care.
All right, amazing. So in a bit, in about a minute or so, you probably can speak to the people of Kenya, being amongst the key people who sit as frontline workers. By the way, we started by always celebrating you people every other way. I don't know where that disappeared to. Well, Kenyans will always be Kenyans, but all the same, we keep celebrating you. We'll be in silence, but yes, we acknowledge what it is that you do. What kind of fear does it instigate, or what originally? Just how were you as medics handling this, looking at the terrible situation of our facilities and the fact that you're human beings before you are medics?
So one thing I must say, we were all scared. I remember when we got our first cases, actually they came in 4 of them in an ambulance. They were not confirmed. There are people who had traveled from abroad and they were brought to our facility. I can tell you they stayed in an ambulance for 6 hours.
As you were deliberating, and what next, who's going to get them?
Who's going to receive? We kept saying we are not ready. So the fear was there. And eventually, being the leader of the group, myself, we had to take up. We had to wear the PPEs and go and receive them, because now it was getting more than, you can imagine, people in an ambulance for 6 hours. So it was not good, but it was the fear. We kept saying we are not ready. So, and that fear persisted for like a month, because people are always scared. Anytime you feel like you have a flu, you're like, I got it. So people really got scared the first time. But actually what helped was the testing. So people kept, we were testing our staff every 2 weeks. And when the people tested the first time, they were like, oh, there's no one who is positive. So people started getting confidence. And this continued the second time. So right now I can say, over time, people now have become very confident. The other thing that has really helped is the ministry has really supported us by providing us with the necessary PPEs. So, and that has been from the start up to now. We've not lacked, there's no day we went without the PPEs at our facility. So even our management and the board, they have really been supportive. And that has really helped us.
And there's obviously that acknowledgement that the PPEs come in handy in protecting our medics. So when you give me back my patient and tell me, we'll take care of them, 0 PPEs, 0 anything back at home, I mean...
No, at home we actually recommend that you must have a mask when you're taking care of them. You must have gloves in case you have to touch any of their belongings. So you still have what we call the minimum.
Like basic PPEs.
Basic PPEs. And then the other thing is you're avoiding the contacts. So if it's food, for example, you're putting it, if you get a table near the door where you put the food there, so that way the patient can pick. Yeah, so there's minimal interaction with the patient. Yeah.
All right. So, lastly, just generally, what would be your advice first to the Kenyans who are watching you today? And is that feel that the numbers have gone down, so we are safe, we can ease up, we can stop, having our masks. As a matter of fact, most of the Kenyans have just worn masks because they fear being
arrested,
or being arrested. So, I just speak to them on a genuine mode, or as a person who's seen and interacts with these patients every other day, just so that they would have that sense sink into their head that yes, COVID is there and it's real, and there's still need for us to be careful.
Yeah. So for me, what I would say is one is that COVID is real. As much as there's a lot of misinformation and fear and stigma, COVID is real. Patients are still coming to hospital, so we must take care. We must wear our masks. We must wash our hands. We must follow the government guidelines of even social distancing. I know people feel like it's not true, but COVID is real, and we must take care and protect those who are vulnerable. Yes. Right.
Dr. Jeremy Gitau, head of Department A&E Department of the COVID-19 Response Team. Thank you so much for the great insight. I've picked some lessons. I just realized that every other time I've been reading news about home-based care, but honestly, some of the crucial things that we probably do not take time to learn more about. Maybe it's because it hasn't befallen us, but when it strikes, it's important that it strikes when you are ready. Yes. And on that very note is where we get to wind up this session of Morning Cafe this morning, as we look forward to see you again tomorrow. But later on in the afternoon, I'll be bringing you the 1 p.m. news. My name is Linda Alela. Do have yourself a lovely, lovely day ahead.